Okay, so good afternoon, everyone, and thank you very much for attending this College of Medical and Dental Sciences Birmingham Professional event. And such is the interest in the subject matter that we've opened out for colleagues across the university. And I can see some people who aren't in the college have attended, which is great. And it's great to see so many people, and the numbers keep on going up as I speak. These events don't happen without significant organisation behind the scenes. And I'd particularly like to thank Aga Zielinska and also Adrian Millard for organising today's event and the logistics around the setup, and also Donna Wiles and the planning committee for their ongoing support and coordination of the college's Birmingham Professional programme. And they really have put on some fantastic events recently, although I think this one might take some beating. As is customary, and in fact Donna's already done it, we will pop everyone on mute who's not speaking. But then following the talk, there will, of course, be opportunities to ask questions. So to today's talk, it's obviously an understatement to say that COVID-19 has had a huge impact on all of our lives over the last 4 months. And of course, this impact will continue to be felt for the foreseeable future and manifests itself in many different ways. And for a moment, in March, certainly, it seemed like the world, certainly the UK, was stopped. Planes were grounded, schools were closed, and most people were instructed to stay at home in their homes in order to reduce the virus. But of course, the world didn't quite stop. And while the vast majority of us were doing our bit by staying at home, some of our colleagues were on the front line of the NHS caring for patients. Some were in the labs conducting vital research into COVID-19, and others were working to set up testing facilities, both here and elsewhere, which of course is crucial in slowing the spread of the virus. So we're here today to find out, well, what was the role of the university in fighting this invisible enemy, and how has our input made a difference? So hopefully to help answer that question, and I'm sure many more that you've got as well, delighted to welcome and introduce Andrew Beggs, who's a professor in surgery and cancer genetics here at the university in the Institute of Cancer and Genomic Sciences, and who's been at the forefront of the UK's fight against COVID-19 by establishing a testing facility here at the University of Birmingham. So Andrew will enlighten us on how this came about, what he and his team have achieved, and I think as well we'll share some updates on the development of a new saliva-based testing system and generally his future work in relation to COVID-19. So Andrew will talk for roughly half an hour. We're not keeping him strictly timed to that. And then following that, there'll be an opportunity for questions. If you have any questions during Andrew's talk, do feel free to type it into the chat, publicly or privately to me if you don't want to be seen as the person that's asked it, and I won't reveal your name. And we'll address those at the end. And of course, there will also be an opportunity to raise your hand and verbally ask a question as well. So I shall shut up now. And so safe to say, on behalf of the College's Professional Services and the Birmingham Professional Planning Committee, I'm delighted to welcome Professor Andrew Beggs. Andrew, over to you.
Thank you. I've managed to unmute myself, which is good. So I'll just share my screen with you now. Hold on. Hopefully you can all see my slides now. I'm just going to put my laser pointer on. There it is. Ooh, technical. Okay, so I've been asked to talk about how the University of Birmingham confronted a global crisis. But obviously this is not a solo thing. There's a massive team of people behind it who have done all this work, and you're going to see some of them today in the photos we've got, and I'm going to tell you a little bit of the story of how it all happened. Before I go any further, I've got some disclaimers. One, I'm not a professional virologist. I'm just an amateur. I play at it. There are many more capable people in the university, in our Institute of Microbiology. By my circumstance I've come in. I'm not a clinical virologist, but I work with many good ones. I may not have all the right answers to all your questions, but if I don't have it, I'll try and point you in the right direction. And there are many people who have contributed to this who I might have missed. It's not deliberate, and if I have, I'm very sorry. And please let me know, and I'll make sure you get the credit. So what I'm going to talk about today is, what did the University of Birmingham do? We'll talk a bit about COVID, because there's quite a lot of mystery around it and quite a lot of misconceptions. I'm going to talk about how we detect and what we set up here. Some of the new technologies and new developments you're going to see on campus and elsewhere. And what are the next steps? So, a couple of things before then. So it's not just my lab with a group of people associated with me who've been doing testing. We've also had many other people in the university. So one of the biggest is Professor Alan McNally, who's one of the directors of the Institute of Microbiology and Infection. And he helped set up the Lighthouse Labs in Milton Keynes, which are the ones you send your postal swabs to, or if you go through a drive-through swab test. And this is one of the biggest, and it's the earliest commissioned Lighthouse Lab. And the three of them, there's one in Glasgow, there's the one in Milton Keynes, there's one in Manchester. They're capable of processing over 250,000 samples per day. So that puts what we've done into perspective. That we're like a small ship. They're definitely the giant ocean liner. But it's, you know, Alan has led those teams helping set them up, and it's a testament that they've managed to get going so quickly and provide so much capacity for the general public. As well as that, there's been Nick Lohman, his team within the Institute of Microbiology and Infection, carrying out sequencing of the virus as part of the COG UK consortium. And as you can see, this is the news article here where Nick talked about how there seemed to be about 1,300 different introductions of COVID. So what that meant is there wasn't just one person coming into the UK who gave everybody COVID. It's likely that multiple people brought COVID back. In fact, they've worked out by doing sequencing of the genome of the COVID virus that it may be up to 1,300 different introductions in January and February and March. So that was a fascinating finding on its own. And some of the sequencing is being done on site here in Nick's lab. Another thing is antibody testing. I don't associate it, but Alex Richter, recently Professor Alex Richter is the one who's in charge of this. And it's controversial. As you can see here, we bought $20 million worth of new coronavirus tests, which didn't work because they were a type of assay called a lateral flow assay. They weren't very accurate. In some of them, you would be better off flipping a coin to decide whether you had coronavirus because their accuracy is less than 50%. So Alex Richter's team, in association with the university spin out the binding site, have designed a really sensitive custom antibody test. And you may have heard the news about the very unpleasant syndrome that affects children called PIMS-TS, which has led to a couple of them going into intensive care in Birmingham, in London, and various other places. And what Alex's antibody test did was show that all of these children who developed PIMS-TS have actually recently had coronavirus. And up to that point, the antibody tests that they'd had weren't very good, and they'd given very equivocal results. So Alex's antibody test has been transformative in the care of these patients. Another thing that's also interesting is that we also did a study of patient staff in the hospitals, which wasn't uncontroversial, but it showed that depending on your role within a hospital, within the NHS, you had different exposure, you generated antibodies to COVID. Interestingly, the doctors and nurses who worked on the intensive care unit had the lowest frequency of antibodies. So less than 10% of doctors and nurses who worked on intensive care developed antibodies to the coronavirus. Yet 35% of the cleaning staff in the hospitals did. More than 30, it was actually 37.9%. And this is all done through the antibody test developed in Birmingham. And that manuscript is currently in revision in Thorax, so hopefully should be with us very soon. But moving on from what others are doing and talking back to what we've been doing, I'm just going to briefly cover what's happened with SARS-CoV-2. Now, we've all heard a lot about it. There's a lot of information that's out there, and it's difficult to know sometimes what information is the right one and what information is the wrong one. So here's the map. This is Hubei province in China, where Wuhan is, and this is where the first detected case of coronavirus an outbreak was reported. And on the left here, this is an email from a mailing list, the ProMed mailing list, where they notify new diseases. And this was the original email that was sent out, you can see, on the 30th of December, saying they detected a novel pneumonia. They're not sure what it is. Can anybody give us some help with this? So that's when COVID started to be known as a problem in late December. So what is it? It's a highly infectious virus, as we all know. And it's from something called the coronavirus family. What other coronaviruses are there? Some of you may remember SARS from the early 2000s, and that's in the same family as COVID, the one we have now. MERS is another one which affected people predominantly in Saudi Arabia, and also the common cold coronaviruses. And they all stem from, they all have a common ancestor here. So here's a picture of a coronavirus. But what we now know is that most of the coronaviruses we see in humans originated from bats. So you may have heard you may have read in the papers over the weekend, there's been some discussion about the study of coronaviruses in bats. So a lot of these have been found originally in bats. But what has become clear is that they need to go through an intermediate animal before they can get into humans. So the old SARS used to have to go through civet cats. It was a particularly bad picture of a cat. MERS, which is the one which affected baby pilgrims on Hajj, went through camels, and that was found to be, they carried it without too many symptoms. But it's thought, although it's not proved yet, that pangolins, which are a type of animal, are the intermediate species. So the bats infect the pangolins and the pangolins infect the humans. There are other coronaviruses out there, and these three ones here, they've got long names, but they are almost common cold viruses. They can give you a severe common cold. And they circulate in the community every winter. So it's not the first time there's been coronaviruses circulating in the community. So you may hear lots of stories in the news about what's in a coronavirus. I'm not going to do a massively detailed explanation, but it's useful to know what all the terms mean when they talk about spikes and nuclear proteins. So a virus is basically just a package for passing on genetic material. So it has to be the package here is a protein package, the membrane protein. The nuclear protein is what holds the genetic code. And this is the spike is the thing that helps the virus force its way into the cells. And so the virus is perfectly adapted to get into cells. And in this case, it gets well into cells in your lung and cells in your gut. And it does that by using a spike to force entry, almost like crowbarring it open and getting in. It releases the genetic code into your cell, and your cell copies it. And the process repeats again and again and again. And that's how viruses work. Now, we've been here before, perhaps. There was a very interesting article in the literature, but also in The Guardian, about an outbreak of a coronavirus called OC43, which now circulates commonly every winter in the UK and gives people no more than a bad cold. But it was thought from genetic epidemiology that perhaps the OC43 coronavirus caused a pandemic outbreak in the late 1800s, early 1900s that was responsible for Queen Victoria's son dying. And so it shows that we may have been here before already with other coronaviruses causing pandemics in the UK. And this died out naturally over 2 or 3 years. So when did it start? This is a graph. I got it off the coronavirus data website last night. It started in England. It started to really take off around mid-March. And as you can see, the number of lab confirmed cases started to go up, where at peak, we were getting about 4,500 to 5,000 cases a day. Now we started testing here. You see where the red arrow is. So we started testing quite early on the pandemic. But our capacity, although reasonably sized, is small compared to the Lighthouse capacity, which is really what put it up. So why did we decide to help? Well, it was clear at the beginning of the pandemic that nobody was prepared for an event of this magnitude. Public health labs are the experts in dealing with these kind of tests, but they are set up to perform hundreds of tests a day rather than thousands, tens of thousands, or hundreds of thousands when needed. And so it was clear early in the outbreak that there needed to be a rapid upscaling of capacity. And the government got the Lighthouse Labs going, but as others said, like Anthony Costello at UCL and Charlie Swanton at the Crick, that there was a need for academic institutions to get involved. And ourselves, the Crick Institute in London, and a couple of other places, Great Ormond Street being another one, decided to set up what we call an academic Pillar 2 lab. So there are different pillars of testing in the UK. Pillar 1 is where you get tested in hospital, and Pillar 2 is where you get tested in the community. So we're what's called a Pillar 2 lab. And we set it up because during the early stages of the outbreak, capacity was outstripped by demand. In other words, there are more people than we had tests for. And this was a particular problem to understand why patients had, which patients were symptomatic, how were positive, and also were there any staff members that were passing it on. And we were asked by our local NHS, the QE and various other hospitals to provide surge capacity, which is what we did. We even wrote a paper on it, as you can see here. And from starting the lab to writing a paper, it took 4 weeks, which must be a new track record in academia. But to give you the background, we set up a rapid diagnostic test in-house, and we could only have done it with Public Health West Midlands and the hospital, UHB. And it was staffed by a mixture of university employees and students. It was amazing how many staff and students gave up their time to come and help. I was literally overwhelmed by a tidal wave of emails from people who wanted to come and help. And the people who didn't come and help with us, a lot of them went and helped in the Lighthouse Labs in Milton Keynes. And so university staff and students were very much used there. And one of the things we did do, which was pretty much unique at the beginning of the pandemic, is all our testing was overseen by state-registered clinical scientists. And you may wonder why that's important. Well, it's important to provide quality control for an assay. And we work very closely with Public Health England locally in order to provide that. Now, I promise this is the only flowchart that I'm going to show you, but this gives you an idea of the workflow. And I'm going to take you through how coronavirus testing works, the journey of a swab. And for those of you who saw it on the TV, we were on BBC Midlands today, and we were also on the radio. This is how a swab comes in and is unpacked, unbagged and tested. So first of all, it goes to the clinical immunology service, then it goes to the RNA lab, then where we extract it, then it goes to the PCR lab, and then it goes to the clinical immunology service. But as part of this being a team, first people we couldn't do it are with the category 3 facility people. Now, Birmingham is extremely lucky in that we have what's called a category 3 facility. What this means is it's one of the highest levels of biosecurity. So it's like you see on the films, airlock doors, people wearing suits like this and respirators to protect themselves against the virus. And that's how we handled all the samples that came in at the beginning. And this gave us an opportunity. The facilities are one of the biggest facilities outside London, but it had been relatively underused up to now because of the fact that there weren't many people who were going to use it. It was originally bought to do hepatitis C. but unfortunately they went and cured hepatitis C, so it couldn't be used for that. So we started to repurpose it for coronavirus testing. People like Dee and also some of the team from Matt O'Shea's lab as well, and Ago, who you've seen on the talk, who are instrumental in getting it going. We soon realised, and the health and safety executive also told us, that you didn't need to unpack them all at category 3. You could do it at something called category 2. And here are some of the staff in the clinical immunology lab. You can see they've got their goggles on, their lab coats, and they're doing it inside these air-controlled hoods where we unpack and unbag the samples. Because when you take a swab, you put it into 2 bags and then you send it off. But we have to unpack it in a safe way to make sure the swab hasn't leaked, and we have to decontaminate it. So it's all very done safely, done to a protocol. We wipe everything down, kill the virus off, and then we take it off to be inactivated. And the easiest way to inactivate the virus in our labs now is we used to have a very toxic chemical to it called guanidine thiocyanate, but there is a national shortage of it. So we invented a method, which others had suggested, of heating the sample. So we heated the sample up, which kills the virus for 30 minutes at 56 Celsius. Now, one of the problems is that then led to lots of samples. And here's just a small selection from one early run here. You can see all the green top tubes here are coronavirus samples that have been inactivated. So don't worry, they're safe. And these are the ones after, these ones here are the ones after they've been processed. And here's the lab here, who are doing the RNA extraction team, some of the people in my lab. And we did this all manually to start with, but then we moved towards getting the robot to do it, which now extracts these automatically without any user intervention. So in order to detect the coronavirus, you have to get the genetic code out of the swabs. So we take the liquid, the swabs in, we run it through RNA extraction, and that gives us the genetic code, the dead genetic code, in order to test for the virus via something called PCR. So we did that in the RNA lab, and just to prove that I do know how to use a pipette, here's a picture of me using a pipette here. This was the first run we ever did. And this is Selena, our genomics lab manager, who is using the multi-channel, because she wouldn't let me out and use a multi-channel. She said I wasn't grown up enough because I'd forgotten all of my skills. But this is me, and this is the first run we ever did for coronavirus testing in the laboratory. And you can see here, we also do that in a hood, not because it's dangerous, but to prevent contamination. Because the last thing we want is to contaminate people's samples, their test samples, with coronavirus from the outside world, because at that stage, none of us knew who'd got it. So we did everything to a very high standard. It then goes off into the qPCR lab, which I took a photo of this morning. So it doesn't look much in that it's just a big room with lots of boxes, but that's how the testing works. But each one of these boxes here, you can see, is capable of doing about 500 tests a day. Sorry, 500 tests a day. But if you look, there are 1, 2, 3, 4, 5, 6, 7, about 13 machines in there. So you times that by 300, it works out to about 5,000 tests a day that we can do in that laboratory. So what happens next? Well, it goes onto the machine and the genetic code of the virus gets detected. And the way it does it looks like this. There's going to be no test at the end. I'm not going to get you to explain it. But this, once again, this is the very first run we ever did of patient samples with coronavirus that came through the laboratory. So this was quite exciting. It was so exciting, I haven't got the time on this. I texted Selena at sort of 10 at night to tell her that it worked, because we weren't sure whether it was going to work. We weren't sure whether we'd done anything wrong, whether it was going to be fine, because we were so nervous about delivering it that we weren't sure. But when it worked perfectly, we were over the moon. And what we did then is we compared it to other people's results. So it's all very well developing a service, but what if it's no good? What if it's absolutely rubbish? So we got some control samples from UHB, from the QE hospital, and we showed that our patient samples were almost exactly the same, in that we could give the same results as a hospital assay. And bear in mind, this was something that we set up in 6 days. So in other words, we'd gone from not having anything to having a fully functioning coronavirus testing lab within 6 days, capable of doing 5,000 samples. Now, we also did saliva, and I'll talk a bit more about that later, finding that it might also be a better test. So I'm sure there might be some people listening in today who've had a swab test. And as you'll know, it's quite unpleasant having a swab test. I'm on the vaccine trial and I self-swab myself, and I find it unpleasant enough. But when somebody else does it to you, it's very unpleasant. So we've done some work on saliva that I'll show you. Now, we've shown that our accuracy is the same as the gold standard test. And so going forward, what the government wants to do, what we're going to offer, is surge capacity. So in other words, if there is, God forbid, another outbreak of coronavirus, another spike of coronavirus, we're in a position now to offer testing to people who need it. Now, what else are we working on that's of relevance to this? Well, sample pooling. Now, one of the things that we realised very soon, and others obviously realised very soon, is that we can massively increase capacity. Because at the moment, although we've got capacity of 5,000 tests, do we need to do 5,000 tests? Do we need to do 5,000 people? Can we pool more than one sample into more than one test in order to try and reduce problems we've had with reagent shortages. So in other words, you heard on the news about people running out of chemicals to test PCR with. So if we could combine 5 or 10 or even 15 patient samples into one and detect a positive within them, and then individually test each of the samples, that might help. And that solution is known as pooling. So it's a way of taking multiple samples, putting them together, and understanding who's positive within those pools. Now, the conventional way of doing that is by these samples arrive in plates of samples, 12 in a column, 15 in a column. So you can just put all the ones in a column together. But the problem with that is that if you do get a positive column, you then have to go back right to the beginning and test all the individual samples within the column to work out who's positive so you can give the patient their results. So thanks to a clever set of mathematicians, I'm afraid to say at Aston University, our neighbours, but they're very good, don't hold it against them, we came up with a mathematical solution called random pooling. And what this means is that we can pool samples together, so more than one sample is in more than one pool. And you may think you've lost me, Andrew. What's that got to do with anything? Well, the reason it's important is by pooling samples in this way, we can infer which patient sample is positive out of a group of 12 or 15. And we can also, using a more sophisticated algorithm, here's the promise, picture of the kitten I promised everybody. Using a more sophisticated algorithm, which you use to do error correction images, we can actually do less testing, but get the same amount of information from a testing plate. And this means that we can pool 17 samples into one. So in other words, we've already done the preliminary run. We know now that we can increase the capacity of the Lighthouse Labs and our labs without doing any extra testing by at least 10 times. So in other words, we should be able to move from 200,000 samples a day to 2 million samples a day without any additional testing, just with more samples coming in. So it's a massive increase, and the University of Birmingham has played a key role in delivering that. What else are we doing? We're talking, one of the other issues is something called you've heard about PCR testing. It's the so-called antigen testing for coronavirus. There's also another technology called LAMP, which we're hoping to implement here for staff and student testing at the university. And one of the issues is the RNA extractor. So in other words, the chemicals we use to get the RNA out of the sample are in limited supply because of the pandemic. Everybody in the UK wants it, and we can't just manufacture enough to make it work. Now, there are alternate methods we can do. So in other words, having to do that step where we extract the RNA, we can just do the test straight on whatever sample it has. So when you do a swab, you can do it on the liquid that comes with the swab. That didn't work consistently well. So we decided to do it on saliva. We decided to use this technique called LAMP. Now, the technique that we used originally for testing the samples, once you put it into the machine, it takes 90 minutes to deliver a result. But the new technique called LAMP, which is a different technique, works in 20 minutes, and it doesn't need expensive equipment. You just heat the sample to 65 Celsius for 20 minutes. And I won't make you go through these curves, but what it basically shows, you can already detect virus in strongly positive people by 6 or 7 minutes. So that's amazing. We can go from saliva samples, we can detect whether you've got, by adding the reagents and mixing and heating to 65 Celsius, we can detect whether you've got coronavirus within 6 to 10 minutes, which is really useful because it means we'll be able to give people a rapid test. Now, we compared it to the swabs we did originally, and it's concordance. In other words, it's very accurate. It compares completely. But the issue with it is it's not scalable. So in other words, it doesn't scale up well. It's a low throughput assay. So it's something we could probably stick in an entrance to a lab or in a hospital, outpatient clinic, or something where we want to test patients coming through. So we have a pre-existing collaboration with a company called Nanopore, who developed a technology called Lampore, which is where we use the advantages of DNA sequencing and this technology I've told you about called LAMP. And very originally, it's called Lampore because it's LAMP plus Oxford Nanopore. And what a nanopore is, it's a type of sequencing instrument that allows you to work out the genetic code. But the advantage is you can pull samples on to it much more flexibly. So here's a picture of what it looks like. This is the gridiron. This is the instrument in our lab. It only arrived on Friday. This is a box. It's about the size of a small laser printer. And on that, it can take 5 what are called flow cells. As you can see here, we can do 5,760 samples in 4 hours on that machine. So if you look at the background here, that machine in the background there, that PCR machine, it can only do about 200 or 300, whereas we can do 5,500. So with a couple of these machines, we could do 10, 20, 30,000 a day on this technology, but it's quite new. And so one of the questions the company we've worked with wanted to know was how accurate it is. So we got version 1 of the assay here, and we tested it on 65 samples locally, and we showed that it's 100% accurate. So in other words, it's just as good as the PCR test that you've seen previously that I've demonstrated to you, deciding who and who hasn't got coronavirus. And the other advantage is it's all automated. So going back once we've extracted the sample and we put it on our robot, and our robot, which is completely automated, will turn the sample into something we can load on here. That process takes about an hour and a half. And then we can then take it to this, and we can deliver data on an automated basis throughout the day and night. The main issue now is some poor soul is going to have to unpack all the samples that get sent in. And as the Lighthouse Labs have it far worse than us, they have a lot of cardboard to deal with, they have a lot of plastic, and environmentally it causes a lot of problems. So I will be completely honest, if we scale up even higher, I'm not sure we're going to put all the cardboard, to be honest. We're going to need some very big recycling bins or a giant bonfire, but I don't think that will go down well. So as I said, the assay is 100% accurate. But one of the other things that we're doing as part of this is doing directly on saliva. So the idea is whoever has this test, you will give a saliva sample into a tube, you will bring it to a drop-off point, and the tube will have a barcode on it, and you'll register your details on a website. And then from that tube, we will take the saliva and we'll directly test it. And we'll be able to tell you at that point whether you've got coronavirus or not, and you'll be able to take appropriate action. And this can be applied to anything. Airport testing, as I'll talk about, it can be applied to staff and student testing here, which is hopefully going to happen. But even more importantly, and we're in negotiations with the government to do at the moment, is we're doing what's called a pan-respiratory assay. So one of the problems with coronavirus is that people who come in with a temperature or a cough or a fever and may or may not have coronavirus. In fact, we know from the literature that only 50% of people who have the symptoms of coronavirus when they're tested actually have it. And that's because a lot of other coughs, colds, bugs, influenza are circulating at any one time. So we're developing, like Lord of the Rings, very Birmingham themed, one test to rule them all. So in other words, a test that can tell you what respiratory virus you've got going on at that moment, which allows you to take the right action. So for instance, if you've got a cold, you possibly don't need to self-isolate in the same way that you would need to if you've got coronavirus. And so it has big implications for how we can look after people going forward. Because as we've all seen from the lockdown, it is enormously disruptive when you get diagnosed with COVID because you have to self-isolate, you're ill, your family have to self-isolate, and now we have to do contact tracing. So it's very important that we try and develop better tests to work out what's all wrong with you. It's almost going to be like a Star Trek style thing. We can tell you what's wrong just by waving a magic wand almost. And what's going on in new directions, just for the final 5 minutes of the talk. So there are a couple of new directions going on. Something called Xpar, all these molecular biology techniques have terrible names, and something called an airport testing. Now, one of our spin-out companies and a team at a company called Linear Diagnostics, as well as our professors of chemistry and biochemistry, Tim DeFawn and Jim Tucker, as well as a PhD student called Jake Carter, have been working on something called Xpar. And Xpar is another way of amplifying the genetic code of coronavirus to detect it. Now, you saw with LAMP, it takes about 15 to 20 minutes. You saw with the PCR testing, it takes about an hour and a half. The advantage of Xpar is it works in 3 minutes. So you can go from your saliva sample or your swab or any test really and get an answer after 3 minutes. And that's enormously powerful because, for instance, if the other advantage is it can be done at a lower temperature. So we can carry, instead of having these massive labs where people come to and they send their swabs to and they get unpacked, we can send lots of little machines to various parts that are important and we can test people for coronavirus within 3 or 4 minutes, which is going to be really important going forward to try and releasing the lockdown, for trying to get people back to work, for making them feel safe more than anything else. Because, you know, every time I know that when we're in the lab, every time you're in the lab, people it gets a cough or a sneeze or look a bit funny, then you get worried, am I going to get coronavirus next? So these new technologies are coming. And the advantage of they're only one of the few good things about the pandemic is it's given us an opportunity to accelerate these technologies that would have been ignored really up until recently. I mean, if we presented this technology to a funding body for testing of any virus beforehand, they would have said, oh, there's no market for it, you know, it's very unlikely to work. And now it's really hot, it's really a hot potato. So it shows that these things are really transforming the way we look at molecular diagnostics. Now, you may have heard a lot about airport testing and about whether we're going to start doing testing at the airports. We are currently negotiating with Birmingham Airport at the moment about starting testing there of all arrivals and departures and airline crew for SARS-CoV-2, using the technology you've seen, using saliva, using LAMP, in order to say, when you get off the plane, you give us a saliva sample, you can go home, and we'll tell you whether you've got COVID or not. Now, the government want to do this anyway. They want to do a swab, but the disadvantage of the swab is they won't do it until 8 days after you've left the airport, and then you have to self-isolate for 14 days after you return. So the advantage of this, we're hoping, is we're going to present the case to the government that if you have a negative test on disembarkation from the airport, then you can just go straight about your business rather than having to isolate yourself for 14 days from an affected country. We're also going to offer this to airline crew, as this is a particular problem for them because they may traffic themselves between multiple countries around the world at any one time. So if we can make sure they don't have anything, that's more useful. And we're planning on using the technology we developed here. And as part of that, it's opened up new avenues of research. I have to say, none of this research would be possible without our one of our clinical scientists from Public Health England, Andrew Bosworth, who's currently on holiday looking at castles. That's what he likes. But he is interested in doing a piece about imported pathogens. He went off and worked on the Ebola pandemic in Africa several years ago. And one of the issues that we have in the UK is that people are bringing diseases back, mainly through UK airports and ports, and we don't know what they're bringing back. So as part of this, we're hoping to spin out what we're doing with COVID testing to test people for all pathogens when they come back. So it'll be voluntary, but in other words, people will be able to provide a saliva sample and we'll be able to test them some of the more rare, unusual things like MERS, even Ebola, but I know that's a scary word, but you know, we can test people, we could test people for it, flu, measles, mumps, and we can test them for antibodies as well. And the idea behind that is, can we actually work out what's being brought into the UK and can we target the screening for people coming back from affected countries so we can reduce the incidence of these terrible diseases here. So, almost on time. In conclusion, the university stood up a diagnostic testing lab in 6 days, which is a pretty remarkable, I think. And the advantage, and I think that's the reason the University of Birmingham can only do this, is other universities, for instance, the Crick, they've done a testing laboratory, they've got a category 3 facility, but they've not managed to do much in the way of antibodies. Whereas thanks to our bioscience background, we've managed to present this full spectrum of different testing methodologies, viral facilities. So we've got the Cat3 facilities to keep the virus safe to do growth. We've got the integration with the local biotech industry that allows us to develop these rapid tests. We've got experts in molecular diagnostics, virology, public health, and we've got a collaboration with Public Health England. They're only based down the road at Heartlands, so they're very easy to do. Now, I put this as potentially because it's very much under discussion at the moment. We might be able to offer staff and student testing when we have a full return back in September. But I would emphasise, I don't know whether it's going to happen yet. There's certainly discussions about it. If we can do it, we will. But we need to think about what we're going to do. So it's an exciting time because hopefully we'll be able to provide some safety for people. Finally, I'd just like to acknowledge everybody in the lab who's played a role in these things. I can't go through them all in names, we'll be here all day. But there are a number of notable people, especially from Public Health England, Mike Hill and Andrew Bosworth, the CL3 facility people who've worked extremely hard to deliver this, the Clinical Immunology Service, our collaborators in the hospital, as well as linear diagnostics. And also, interestingly, until very recently, a lot of this research was funded off my core grant, but now it's being refunded by the government. But it just shows that sometimes funders step up to the mark and deliver really important research and also testing when it's needed. And I'd just like to leave you with a photo that we took on the medical school steps that everybody's seen, I think. Which I have to say was done with an iPhone after a very hot day when we were all a bit tired after doing diagnostic testing. And I got home and thought I'll just put some sepia tones on it with Instagram. And everybody said we looked like a rock band, but I'm not sure you could ever apply that to a load of scientists. Thank you very much. And I'll stop if I can get it to stop. There we are.
Andrew, thank you so much. That was wonderful, and you've got me thinking of rock band names actually. Now I'm wondering, anyone with ideas for that? You know, we'll have to names on a postcard. I think if we were in the Leonard Deacon Theatre, the applause would be ringing around the lecture theatre. That was fantastic. It was informative, light-hearted, and I think actually pitched just perfectly for an audience of professional services, but of an interest, obviously an interest in COVID-19, but also an interest in science. So the way we wanted to try and do this was for me to try and manage the questions coming in on chats, and one's coming to me privately, so I can read that out. But Donna, you also had a couple that have come in beforehand. Do you want to perhaps start with those while other people are thinking about what questions they might have? And then if you do, people watching do want to raise your hand, I believe there's a way of virtually raising your hand, although I don't actually know how to do that, but either virtually do that, and I think Donald knows how to catch you, or if not, just go crazy on your screen, and I'm sure we'll spot you. Donna, did you have a pre-sent question?
Thanks, Andrew, for making that so easy for people like me with not really any scientific knowledge to completely understand it. That was great, thank you. One of the questions I had through, and I know we've briefly touched on it before the event started, was about frozen food. So you're collecting your frozen groceries from the shop, and it's whether or not the virus actually survives on packaging, whether or not freezing kills it, or whether it remains dormant, and if it's live again once it's taken out the freezer.
So, as I said, I'm not a professional virologist, but we have looked into this as part of, we have to inactivate the virus before it comes in the lab for testing. So we've had a look in the ways of activating. Now, freezing in itself doesn't kill the virus. We use it to preserve it, to wake it up again when we need to test it. However, the risk of transmission, there was a paper recently published on medRxiv, which is a preprint service, which is not peer reviewed, shows that the risk of transmission from services like that is low. And, you know, there are simple things you can do. You can't really leave your frozen food on the side for 72 hours to decontaminate, but the risk of it being contaminated in the first place is quite low. And the way to look at it is, especially at the moment, if you look at the amount of coronavirus there actually is in the UK at the moment, there's very little. The amounts have gone down. And people are being very vigilant, they're washing their hands. And given that the primary method of transmission, when it would be from frozen food, would be it would go from the food on your hand to your mouth. All you have to do is be careful, wash your hands. If you're worried, wipe things down. That's a good way of doing it. But the risk of transmission from that route, from what the literature suggests, is very low.
Thank you. Just while waiting for any further questions to come through, there was another one. It seems that everybody's a little bit aware environmentally these days on how many masks we're throwing away and how many gloves we're throwing away. If like it's been announced in the news, it lives on services for about 72 hours, are we quite safe to reuse masks if we put them to one side for 72 hours and then just reuse them again to allow time for the virus to die off naturally?
I mean, personally, I've got this mask, which you've all seen, probably on other things. It's a striking a balance. The thing about masks is my cloth mask gets washed every evening. I just put it in the washing machine with my wife's and various other things, and it gets washed every evening. The disposable surgical masks, they do lose their effectiveness over time. And as a surgeon, when I'm clinical, I wear a mask every day. I wear them in theatres, and we change them between patients. But the whole masking, it's a very hot political potato. Obviously, I mask, but I'm not going to pass judgment on people who don't. But one of the things about wearing masks is you can only do your best. And, you know, if you're struggling to get hold of masks, some face covering's better than none. And yes, you may end up putting a mask back onto you that has virus on it, but you're not going to know. So try and change masks when you can. Try and get a reusable cloth mask, wash it regularly, and that's probably the best thing to do rather than using disposable masks over and over and over again. And it's better for the environment as well, because you've all seen litter of masks everywhere. I know I have.
Thank you.
So one question that's come through to me to ask you, Andrew, is, it says, I'm sure you probably explored many other techniques before you identified these novel, rapid and high throughput techniques. So what other techniques did you explore which have not delivered? The first part. And also, can you talk about other techniques being developed in other labs in the UK? Yeah,
sure. So other techniques that haven't delivered, I mean, we didn't really explore many because the issue was to get the lab working quickly, we had to use a validated technique that everybody used. And so at the beginning we used PCR because it's the diagnostic that Public Health England use. It's a validated methodology. We know it works. We got it running quickly. In terms of other tests that other people use, the Lighthouse Labs are, one of the things that's being talked about is something called endpoint PCR, which is where you basically still do PCR, but you use a sort of plastic 3D printer to print sample wells onto a massive roll of plastic. And you put the patient's specimen into it, and then you do the PCR by dipping in wells of hot, cold water, which sounds insane, but is potentially very, very, very high throughput. In terms of other methodologies around testing, there have been people trying acute antibody testing of saliva, of blood, of respiratory samples. They haven't performed very well, and I know they're not being considered. There have been just simple tests like, you know, is having a temperature and having a cough enough to know you've got coronavirus? The answer is no. I mean, you have to do some kind of molecular testing. I mean, that sort of falls into what people ask about false negative. Is it possible to have a negative coronavirus swab and still have the virus? The answer is yes. The answer then is usually because the swabbing's not been very good. And we've got a paper that we're writing at the moment, I was doing it earlier, which shows that actually swabbing yourself is better than getting a drive-through person to do it for you. Probably because if you have somebody else shove a swab deep into your nose, it's quite uncomfortable in recoil. But if you do it yourself, because you're desperate to get a good sample, you will do better. I know people have quoted a false negative rate of 30%, but my experience is not the case.
Fantastic. And one's come in here from Alice. Let's just see. I have a double-layered cotton mask.
I've got that one as well, yes, I saw. I've got double-layered cotton mask. The advice is to wash at 60, but living alone and washing a single item at 60 is not very economical, eco-friendly. Is it okay that I steam my mask instead? I'm hoping it's to steam about 100 degrees. So if you look at, there's a graph I won't show you because I don't know where it is at the moment, of different temperatures' effect on coronavirus. And 95 Celsius does kill it quicker, but you still need to be exposed to 95 Celsius for 10 minutes. And I don't think that you could expose your mask via a steam iron to 10 minutes of it because it would probably melt or set fire to the mask. So unfortunately, yes, you are going to have to wash it at 60 Celsius in your washing machine. Or the other possibility is you boil a kettle and put it, I mean, this is just completely made up, so don't take this as proper advice. You can boil a kettle, fill a jug up with water and just shove the mask in there for 10 minutes. And I imagine that would probably kill it off as well. But the best thing to do is to wash it at 60 Celsius for 30 minutes.
Fantastic. And we've got quite a specific question here. To get 100% concordance between the PCR and the Lampore?
Yes.
How many samples was that based on?
192.
And one question that I've got, to set things up so quickly, so rapidly in 6 days, I don't mean this probably the way it's going to come out, but kind of what were cut or what processes were just absolutely massively fast tracked that normally would take several weeks in order to do that because you didn't have the time to.
So I think a couple of things. I think one, the Health and Safety Committee were very good, and that if I email them, I generally got an answer back the same day or the next day, and it wasn't bypassed, it was just sped up massively. Normally a health and safety review would take over 2 or 3 weeks, whereas we were getting it back in less than 12 hours. I think the other thing is just to go to actually the technical staff. The Institute's technical managers were very, very helpful and supportive during all of them. And it got to the stage where we were going around with trolleys and picking up real-time PCR machines from labs and just delivering them to our lab. So that's not normally what would happen, where I basically stage a raid into somebody's lab and take a machine. But, we did that because people realised it was important. And so I think those are the sort of things that were bypassed. IT were very good as well. When we needed his machines networked, I would email IT and then suddenly somebody would turn up within about 5 minutes and wire everything up. And obviously they're very overstretched normally, and they're overstretched every time, but they were able to come in and help us with that. So it really was a complete university effort.
That's fantastic. It's fantastic to hear, and it's interesting because you think sometimes it's just the scientists, I guess, doing all the work, but of course all the rest of the infrastructure around.
We couldn't do it. Actually, another one, the cleaners. So when we started the lab, because everything had shut down, before the building wasn't being cleaned, because nobody had thought that we were going to be there. So I sent an email to the cleaners, not expecting anything, and literally within about 2 minutes, an entire army of cleaners turned up and started blitzing the building, and they were amazing, and they continue to be amazing, and they were really great. They came in every day when we were doing testing, they cleaned the environment for us, they were really careful and meticulous, and they were really a credit to the cleaning staff. It was amazing.
It's fantastic team effort. One here that I think you can see as well, and from Georgina.
Yeah, this new test that you created such speedy results look like it should be implemented countrywide rather than just Birmingham. Is this a possibility plan? Yes, it is. The trouble is, it's not me, it's not you I need to convince, it's the UK government. And we are convincing them at the moment. We have to go through it more seriously. We have to go through a validation process. We have those assays at the moment, they have to go through what's called CE-IVD marking. Like you see a CE mark on a toy, you have to have them for medical devices as well. So we have to assemble enough data in order to prove that the test is just as good as what's come before. And one of the issues with that is that we do have a lot of banked samples we can use, but we need to use some fresh samples as well. And we're running, as awful as it sounds, the amount of number of patients with coronavirus has decreased so much, we barely get 1 or 2 a day locally. And so we're not getting many positive samples to sort of cross-test on. So that's having an impact on how we make it work. But yes, as far as I'm aware, having spoken to the government about this, the plan is to take these rapid tests and pooling and various other things and use them to massively increase testing capacity.
Fantastic. Right, 3 have come in to me privately, so I shall ask you these. Are various oops, they're coming in so fast, they're slipping off the page. Are the various coronavirus test specific to SARS-CoV-2, or would a patient having another coronavirus also give a positive result?
It depends on the test. So most of the tests, with a few exceptions, are what are called multi-gene tests. So the coronavirus, the SARS-CoV-2, like most coronaviruses, is made up of multiple genes that do different things. So the one that we use has got, three genes in it, one called E, the envelope gene, one called N2, so the nucleocapsid gene, and another one called ORF1b. And so we only call a positive when all three of those are positive, and that's very specific for coronavirus, SARS-CoV-2. Some of the older tests when they first came in were quite non-specific in that they would highlight if people had normal coronaviruses, the sort of winter circulating cold ones. But now the majority, in fact, almost all of the tests are very specific for SARS-CoV-2.
Thank you. And one question, I know this has been in the popular media, as it were. Is it too early to understand any long-term health effects, other long-term health effects of contracting COVID-19?
No, I'm not saying this to generate sympathy, but my wife has been quite severely affected by COVID. She had quite mild symptoms initially, but then she has ended up being one of the ones in the media called the long tailors. So she's had neuropathy, arthropathy, vasculitis. She's had quite a terrible time. And, she had coronavirus back in early March, and she's still suffering from the aftermath of the symptoms. There's certainly a cohort of people who've suffered terribly from this. Now, we don't understand exactly why that is, and there needs to be research into it, and that's what's going on. That research will start in various groups. What I can say is that from my own very personal experience, people do get better, and she is getting better gradually, but it is terrible, terrible disease. It does seem to be quite related. If you look at SARS, the original SARS that affected, actually interestingly, Korea back in the 2000s, the patients there tended to have quite long-term problems, some of them with after being exposed to SARS. And we think that's what the literature seems to suggest. That's what's happening here. We don't know where we're going, but I mean, the general direction of travel for most people is they are recovering.
Yeah, well, best wishes from us all as well to your wife. Very quick one here. Do you believe in a second wave?
It depends what you mean by second wave. As you've noticed at the moment, once again, I'm not a viral epidemiologist, and there are plenty of good ones in the medical school and in bioscience who can answer that question better than me. There are things that are very different from where we did it before. People are wearing masks, people are washing their hands, people are socially distancing, things are locked down and reopening. I think what's more, I personally, and this is a complete personal opinion, I think what's more likely from what I understand of how viral transmission occurs is that we'll see very localized exacerbations like we've seen. I don't know whether you've seen, there's recently been a fruit farm in Malvern where there was an outbreak amongst the packing workers, and something like 200 had to self-isolate and 60 had coronavirus. Leicester is another example. There was a massive spike in cases. Burnley, Preston. I think that's what we're more likely to see because the systems are better for detecting it. So I think going over the winter, I mean, there was some news today about how we might have a second spike, but that data is based on the fact we're not going to do another lockdown, that we're not masking, that we're not washing our hands. So I think things will be, I think there'll be more, I personally think there'll be more local outbreaks, but you may want to ask a professional virologist for a proper opinion.
Thanks for answering it anyway. Another one here. Has there been any MHRA involvement in the development of this test?
Yes. So as part of this sign-off, the way it works at the moment, the regulatory landscape is obviously given by, somebody who's asked that question is obviously familiar with the landscape of testing accreditation. So the way the landscape is at the moment is that to have a test approved, you have to submit the regulatory documentation to NHS England, who then liaise with MHRA and something called the validation group to approve it. And actually at the moment, I believe we're the only academic laboratory in the country who's got validation and sign off from the MHRA and NHS England. So there's a process you have to go through, a very strict quality control process. And there are other frameworks you do. There's one called UCAS. So we're UCAS accredited under the Clinical Immunology Services framework. There's also ISO 15185 that we're also accredited under. So yes, it has to be done through the MHRA, but the current route is through NHS England.
Thank you. I must say you're doing exceptionally well answering all these questions because there's no panel. It's just
I've heard them all. I've heard them all before. I've been asked these before.
There's one here from Nadine, Brian, which I think you can see, around family members working in care homes.
Yeah, someone is tested weekly and the other hasn't been tested. What is the recommendation of staff and residents in care homes? There haven't been any recommendations, unfortunately, as far as I'm aware. Unfortunately, that's a decision for the care home and for public health, the local public health environment. The testing, because a lot of care homes are private entities, they have to make a decision on testing. And unfortunately, some test homes will test weekly and some won't.
Great. Another one here about masks. Are certain homemade masks better than others? For example, three layers of fabric or one with a filter?
I think the answer is it is an evidence-free zone. We know that masks are probably protective, but what we don't know is which one is the best. Beyond the FFP3 masks that you've seen, those are the proper fit tested masks that we wear in the hospital. We know those are more protective than a cloth mask, but it's very difficult to properly model how good these different forms of masks are because they're all based on theoretical models. It's not really ethical to give somebody a mask and then expose them to COVID, which is a good thing. Obviously, we're never going to do that. That's the only way we're going to know for sure. But I think any kind of face covering is better than none.
It's interesting the price differentials. You know, it's almost like they are based on scientific evidence.
Well, this one was I think £5 from a chemist in Leamington Spa where I live. So I'm very happy to give you the address if people want to know it. It's very comfortable.
A question here. It's quite a nice one. Have you enjoyed working on COVID and being involved in this? And let's expand on that. How's it been for you personally?
I have to say it's been quite stressful. It's definitely been good, but it's been good to help. I'll put it. That's the most positive thing to say. It's been really good to be able to help in a way that I couldn't have done. I could have gone into the hospital and just done clinical cover for the patients there, which would have been just as useful. But in some ways, it's a bit like why people do public health. I think I've been able to make a bigger population difference. Us as a lab have been able to make a bigger population difference because we've been able to do all this testing, get these new tests working, and it's really helped people.
Yeah. And when just as a follow on from that, I became aware of coronavirus. I can't even remember really, and then as a university, we became aware of the massive implications on having to work from home and the lockdown early to mid March, wasn't it? When did you realise that this was going to be now your work?
I think I realised bizarrely when they started cancelling clinics in the hospital because of coronavirus. Then I realised probably this is what we were going to have to do. And when they start, we started planning before they shut the labs down. And so that's when I first realised.
Right, so not a great deal, not much longer before the rest of us, really.
No.
Question.
I've got a couple of private questions somebody sent me.
Oh, sure. Go ahead.
I'll just bang through. Do I think that University of Birmingham will set up a free staff student annual flu COVID testing station? The answer is probably we will set up some kind of COVID testing station. That's the college council. That's the UEB University Executive Board to make the decision on. But we've got the facilities if we need doing it. Number two, another question was, is testing only necessary when you have the symptoms? Because if you catch it the day after you've tested, isn't it useless unless we keep testing? We have done an asymptomatic testing piece. So when we tested staff in the hospital who were asymptomatic, I had no symptoms, the rate at the height of the pandemic was 3%. And so in other words, of all the people we tested without symptoms, only 3% actually had COVID in the hospital. And then it very rapidly decreased. And for the last last 2 months, it's been 0%. So we've had very, very few cases. So, and even when you are symptomatic, the positivity rate is only between 40 or 50% normally. We had one day where it was 100%, but that's very unusual. The third question, can non-MDS staff volunteer to work in the Lighthouse Labs? The Lighthouse, I believe, are not taking any volunteers anymore. It's an employed thing, and you have to apply via their website. And is sample information kept? Or are you breaching data protection if you can identify people using their DNA information? We only keep 3 points of information, but it's stored within the Clinical Immunology Service as an NHS computer framework. And so all patient-facing data is stored within that framework, so it's confidential. Number 5, the final question I've got is, number 6 as well. Why did you not wear a face mask when working in the labs with the samples? Because the virus had been inactivated, so it was safe. Do you think that face masks are good for protection? Yes. And when do you realistically think a cure will be found? I don't think a cure will be found. I think a vaccine will be found, but I don't think a cure will be found. And that's all the questions I've got.
Fantastic. We've had one here from Hannah, but I think you've answered that one around will we have to wear masks when we return to campus. Was that the UEB?
No, that was about testing. So about masks coming to campus, I think it depends where you are. So the email I've seen, we were sent in the Institute, which is the same everybody in cancer science was sent, is it's a matter of local risk assessments, and that no decision has been taken on masking or unmasking. I mean, what I say to my lab is they're very, very happy to wear a mask if they want them to, but it's a decision that has to be made at a university level rather than I'm not going to, I haven't got COVID, promise. It's not a decision that I can make. It's something that has to be handed down from the university, and then I'm happy to facilitate in whatever way people want.
I want to hear from Jess. The likelihood of an effective vaccine in the recent in light of recent news about antibodies only lasting for a few months?
Yeah, so there are a couple of vaccine candidates that are around at the moment. I've had, well, I don't know whether I've had the vaccine candidate, but I'm in one of the vaccine trials, the Chaddox vaccine, the Oxford vaccine. And all the animal data seems to suggest that it does provide reasonably lasting immunity. But yes, like you say, we don't know how long for. The thing to compare it to is they developed a vaccine for the MERS virus that you saw that uses exactly the same backbone as the one they're using for coronavirus. And that does provide long-lasting immunity. So I think they're hopeful that it will do. There's another vaccine called the Imperial vaccine that you've heard about, which hopefully Birmingham will be taking part in running a vaccine trial for. And it is also being shown to cause long-lasting immunity in monkeys and also in humans now. And I'm quite optimistic that we will develop a vaccine. Whether it will last permanently for all your life, it's difficult to know. It's more likely, I think, it'd be like the flu vaccine where you'd have to have a top-up every year.
Well, we have one question here around what sort of enhanced cleaning level or enhanced level of cleaning and hygiene should we have in place for staff returning to campus? I'm not sure whether that's totally within your remit.
Well, I can say what's happening here because we've been in. I've seen the enhanced cleaning measures, and so the cleaners are blitzing at the moment. I mean, you come in and the smell of bleach and chemicals and everything is quite intense. So they're definitely going to town. I think it's hard work for them, but I think they secretly enjoy it because they get to use all these hardcore chemicals that blitz everything. The social distancing also helps, and people are being a lot more careful. So, I mean, there's definitely enhanced cleaning going on, and they're definitely taking all the right measures at the university.
Yeah, and just to add to that, I think I can add from what I know is that anyone who returns to campus as we gradually open needs to go through and do some an online course, Canvas course as well, to take you through the various measures that personally we need to take. There is a rigorous process for how the buildings reopen and how many people you can fit in certain spaces. So that will happen in every single building that is reopened. So it will be done to the absolute safest possible way. So don't worry about that. There will only be staff to the capacity that can be done safely.
So, for instance, we've got specific numbers of people that go into offices. We've got a one-way system. Only a certain number of people allowed in a certain number of rooms. I feel like we should do a little video of walking around to show you what it's like. It's very, very different to what you would have experienced before. It's very, very safe, and it's unlikely. I mean, that you'll run into problems with it.
This might need to be the last one. Just keeping an eye on time. So, Georgina, shops seem to be using the Antibac gel route. Is this actually any good if the gel has no bleach in it?
Well, actually, this is where I get to tell you, yes, it is. So one of the things we do know about coronavirus is that it's killed by 70% ethanol. So all of these hand gels that like you see in the hospital across the way, the Antibac gel that you get, they've all got denatured alcohol in it, at least 70% concentration. And that, as long as you put it on your hands and rub it in thoroughly and let it air dry without wiping your hands, that will kill coronavirus for sure. Which is unlike other viruses, for instance, norovirus, which everybody hates. That doesn't get killed by alcohol gel, but coronavirus definitely does. So alcohol gel is really good.
Right, we've probably got time for one more if anyone has got one.
I've got one sent to me privately. Will the test detect if a patient's previously been infected with COVID-19? So my test won't. The test we do won't. The antibody test perhaps, but one of the issues we know from the media is the antibody tests are not quite as good as we thought they would. So we're working on something called a T-cell mediated immunity test, which I'm not allowed to say anything about at the moment because it's under an NDA, non-disclosure agreement. But watch this space. We're trying to develop a next generation of immunological tests to tell you whether you've previously had it, whether your body's been exposed to it.
Right then. Well, just about on time. Andrew, thank you so much for giving your time, your highly valuable time today. You've given a wonderful explanation of a really complex concepts to a non-scientific audience. Hang on. So thank you on behalf of all of us for today. But also what you've been doing and what you're going to continue to do. I think we're all massively indebted to you. Donna is about to unmute everyone, so we can actually give you a round of applause. So go on then, Donna, do your stuff.
Someone just...
Can we do that? Or if you can unmute yourself and you give Andrew a round of applause.
Good luck on muting 200 people.